All right, welcome everybody to the now 10th week of the Business of Healthcare HCBiz chat and blab combo. Really excited today to have a bunch of great guests to come on and talk about direct primary care. It's a really interesting model. It's been around for a couple of years at least, I'd say. It seems to be getting a lot of traction, a lot of attention now. It is, I won't even get into the definition here. I'll let you guys explain it. You're much more versed in this than I. So, we're just going to dive right into Business of Healthcare chat. For any of you guys, blab and chat combo, any of you guys that are new, is we pick a topic every week, and we're coming at it from the standpoint of what are the business frictions to getting these types of things done. We're not here to talk about silver bullets. We're not here to complain about the way things ought to be. We're here to talk about how they are and what the tools are and what the problems we're trying to solve, and trying to come up with real workable solutions that we can do today, not in 6 months or 18 months or maybe in 5 years once legislation allows for. So that's the basis for the show. Shahid, Shah, my co-host, is here again with us. Go ahead with a quick intro.
Yeah, I don't know how to beat that intro. I mean, talking about realities of healthcare instead of hand-waving and screaming and complaining that we see so much of in the general media. And my expertise is primarily on the system side. I'm an architect and engineer by trade. I do a bunch of entrepreneurial work as well. And I'm really excited about today's topic because it is an area that I've worked in for a number of years, especially on the system side. So looking forward to it.
Awesome. And we've got a couple of guests on here. And as I mentioned earlier, there's at least 1 or 2, maybe 3 more people that might want to jump in. Kat, Quinn, I saw you just jumped in here, and we'll give you a chance to jump on later and chime in. If you've got some specific things that you want to get in on, just start yelling in the side panel and get our attention. And who we have on with us today is Mr. John Chamberlain. Quick intro for you.
Good morning, Don and everyone. My name is John Chamberlain. I am a recovering hospital CEO and have been involved in the direct primary care space probably for about 4.5 years. I have a small company called Primary Care Direct, and I also work with a firm out of Nashville called Medical Access USA, and both businesses are involved with direct primary care.
Excellent. And Dr. Randall Oates, thank you as well for joining us. Do you want to give us a quick background on what you brought you here and got you into DPC?
Sure. Well, when I left my group medical practice back 10 years ago, I opened a cash on what was the first direct primary care practice in the state of Arkansas, and I closed after about 3 years. I was too busy and distracted traveling. My main occupation has been as a physician executive. I'm the president and CEO of Soapware My Healthware, which is an EHR and a patient-centered cloud platform. And my real passion, the real irony of it is I love family medicine. I mean, I really love patient care, but I hated charting. Hated medical records. So what did I do? I created a medical record company. And but really my passion now is how we can get back to more professionalism, create more face-to-face time, less face-to-screen time. I'm really fired up is what is the true nature of engaging patients, and what really excites me about direct primary care, it's really the area where they get it and they have the incentives to really optimize the tools and the technology to do what patients really want and what true professionals really enjoy doing. So that's why I'm here.
Awesome. And you are HCBiz. You didn't like charting, so you went and built a charting company. I love it. So, all right. So why don't we start? I think everybody here probably at least has the basis for what is direct primary care, but why don't we start right there? John, what are we talking about? Direct primary care, what's the difference between that and a traditional model, concierge care, things like that we're hearing about?
Direct primary care, at least the way I explain it to folks when I'm doing so, is that it's similar to concierge care. A lot of folks are familiar to some degree with concierge care. It's been around close to 20 years, maybe a little longer. And the differentiators for me between DPC and primary and concierge care are, first of all, it's what I call concierge care for the working man. It is typically less expensive. The second differentiator is that in a pure DPC practice, there is absolutely no insurance being filed whatsoever. In a concierge practice, insurance is typically still enforced. And the reason that's important between the two is that in a pure DPC practice, you, by not filing or accepting insurance, you automatically remove between 30 and 40% of your overhead in that practice, because that's how much overhead is associated with employing staff to handle insurance, chasing claims, getting denials, crossing T's, dotting I's, going back to what Dr. Oates said. And it also completely removes all the government and regulatory restrictions that are associated with our current insurance-based practices, all the alphabet soup. It also allows a physician much more time, and this is probably one of the most important things, and it's somewhat similar with concierge. It allows the physician more time with the patient and subsequently with the physician's family.
Got it. And anything to add to that, Shahid or Dr. Oates?
Yeah, let me just add one thing, and that is that, and we've chatted about this at HCBiz for a number of weeks now, that medical care in America is very heavily intermediated, which is why the D in DPC matters quite a bit. Right. Whenever something is intermediated, people's incentives for what they need to do and what they ought to do and what they will be willing to do are determined by different people. So, for example, in our intermediated care model today, the government pays, but it gives money to an insurance company, which then hires or passes money through to physicians and to health systems. And then the health systems are then bound by that reimbursement that they're getting, as opposed to what might be most beneficial to patients. And that's called intermediation. It's our whole system is heavily intermediated. So when we're looking at the business models and we're looking at how to improve care, the more we can disintermediate and deregulate, if possible, in that market, then the more closely we align to direct care, which means that patients and their families and their caregivers can drive the equation far better than they could in an intermediated model. Now, in a large sense, what we see our panelists doing today is difficult because everybody believes that, in America, healthcare must always be intermediated. And I think that's the big challenge over the next several years, is to make it clear, no, the rest of American economy is completely disintermediated. Consumers drive what they need. Right. And healthcare should be like that as well. And it's so weird that we have to say that and sell that concept in a heavily democratic environment, in a heavily capitalistic environment, where we say, you know what, patients, you should be able to drive what you want, and your family should be able to drive where you want, instead of insurance companies or the government or others being involved doing so. So as we talk in this next half hour, 45 minutes, it'd be good to really figure out where DPC works and why, but how we could put portions of DPC into even the intermediated model. And next week and over the coming weeks, we're going to talk about the comprehensive primary care and other level of disintermediation that's occurring through population health, care coordination, patient engagement, and these kind of techniques. So just wanted to kind of lay that out, is DPC is the opposite of intermediated care, which is where we are today, and that there are benefits to it, but it's also got an uphill climb because the other intermediated markets are so heavily present that it takes a while to get around some of the natural walls and barriers that they've stood up, because it's so beneficial to so many different participants other than the patient.
Right on. Anything to add to that, Dr. Oates?
Well, gosh, the guys have summed up things so well. And what I'm, I spend a lot of my time visiting practices, and it just is fascinating to me. I mean, I visit practices that are very much a part of the intermediated model and have reached a very high level of efficiency and are doing okay. And then the practice is doing primary care. the atmosphere, the tone, the spirit in the direct, where there's direct relationship with patients is so refreshing. It's just a joy to go into those, and it's obvious that the professionals and the staff and the patients are just in a better place. They're more satisfied, and the evidence is that, ironically, in this period of health reform, and we're looking at the alternative payment models, they jump up and down if they see 2 to 5% cost savings. And there are many DPC demonstrations of pilots where they're seeing 20, even 60% cost savings, much higher satisfaction levels. And by true measures of quality, I would argue their quality is much higher. To me, it's just a matter of time where the undeniable failure of being able to centrally define what is value and try to intermediate that is just going to it is so misguided and so invalid that it creates chaos, and the chaos begets the need to alter and create another more complex and chaotic system, which it gets even further from there's going to come a point in time where people have to step back and say, let's look at the real evidence. And when you look at the real evidence, the more that professionals can have a direct relationship with their patients, the better the outcomes are proving to be. And I'll just want to say right up front, my real bias is, how can I get you smart guys to collaborate, work together to create incremental transition paths where we can get to from where we are to a better model. My bias is that in order to get to DPC, most of the practices I deal with would love to have a direct pay relationship, but it's just the burden and the risk of suddenly flipping the switch and going 100% DPC and throwing out 3/4 of the practice is just not tenable in many practices and in many communities. And then the doctors having to moonlight for 18 to 24 months in order to maintain a standard of living. Why can't, there are proven models, like you mentioned Lee Gross before we got on, who is doing a hybrid transition. He's gradually dropping the most abusive health plans over time as his panel of direct pay patients is growing. He eventually intends to be 100% direct primary care, but he hasn't had to turn anybody away or throw anybody out. He's come up with a very, I think it's clever model to facilitate an incremental shift over time that I'm really excited about. Whoever the entities that figure out how to collaborate with practices, because doctors are not businessmen. They don't understand how to market, or even why often it's really valuable, and they need guidance. But they need guidance by entities that have flexibility to adapt to them, their style, and their community. So I'm optimistic that what has been a trickle, I think there's around 4,000 to 5,000 practices with direct pay models. But if you look at surveys, over half of physicians are intrigued with the concept and would love to in some way offer that solution, but they just don't see a path.
So do you guys think that, so if you look at the three major concerns, I think of at least physicians and physician offices that I've spoken to, number one, is it legal for them to do this? So for some reason, people believe it's not legal to charge a subscription fee, even though that's what insurance is, right? You pay a subscription every month, and then you get services rendered on those. So regulatory-wise, and one thing I'd like to cover maybe in this, for especially you two experts, is number one, what do we believe the state or federal regulations are that prevent DPC, and are those myths or are they real? If they're real, where are they? So one part is regulatory. The second piece is, is there enough knowledge about the standard of care outside of insurance, where physicians and nurses, et cetera, understand what their jobs are if insurance isn't there? So processes, procedures, manuals, training, is that all there? Because there's plenty of training and other things to run a practice in an insurance administered model. And then the third piece is, do we have the technologies and capabilities that we need to service DPC companies? And what I mean by that is, it may be a third-party integration ecosystem, like a support company, which helps multiple physician providers say, okay, we'll provide you air cover, much like an IPA or something does with insurance companies, or a GPO does with suppliers. So these three areas: regulatory, number one. How do you get your workforce to work in a DPC environment, number two? And is the support ecosystem of technology, et cetera, ready? I just love for you guys to talk about that. And maybe as we bring some of our other participants through, they could answer those three questions as well. Because if it's real and it can be done today, why aren't more doing it? And it's possible it's one of those three problems.
I'll jump in and take on the regulatory. There are 17 states right now that have either passed or have legislation in process. And the primary reason for doing this is to get around every state's Department of Insurance, who regulates insurance products. And the follow-on to that is, if you don't have that confidence in your back pocket, then there is a likelihood that insurance companies, being who they are, might challenge the fact that a DPC practice is not an insurance-based practice. And the reality is, and the 17 states that have passed it so far, they have gotten a ruling based on their legislation from the departments of insurance that it is not an insurance product. That is a fear that I think a lot of people don't necessarily address first, but that's a real fear. That's a real possibility. I don't think it's ever happened, to my knowledge. Tennessee right now is in the final stages. The bill, the DPC bill, for lack of a better term, is sitting on the governor's desk awaiting signature. It's been through both bodies of the legislature, lieutenant governor, et cetera, et cetera. It happened fast, and the reason it did was actually one of my colleagues in Nashville and some of his drafting partners put the legislation together, and they involved the DOI from the get-go. They asked the Department of Insurance to come and talk about preparing this bill for approval. Interestingly enough, the state of Tennessee is also, they have a very active state senator, Patrick Colbeck, who is proposing actually a Medicaid pilot to TennCare, 2,400 Medicaid enrollees. He is suggesting that there is a 20% conservative, 20% savings potential. And I agree that's a number I keep hearing. And the savings is important, certainly, to states. But the real bottom line for me is it's better patient care. Savings is important. We're in the mess we're in my opinion, because we have relied for 50 years on employer-based insurance. And typically, being a male, we are probably more guilty than our counterparts in going to see a physician when it would be much more prudent, and then waiting until we have chest pain to head to the ER. But I think from a regulatory standpoint, it would be prudent for all states to at least put legislation forward to protect those DPC practices.
So do you believe that from a regulatory perspective, is that fear well-founded and well-earned, or do you have to do kind of like, and I've mentioned this in one of our previous blabs, there was a nice article written by, I believe it was Sloan or at Wharton, where one of the professors wrote an article called Your Regulatory Strategy is Your Innovation Strategy. Right. Being that you have to challenge these things, not make people take you to court or arrest you or something, but you have to challenge the notion that it is illegal and just assume it is legal and have someone come to you and tell you it's not. Is that me being naive, or is that something that could be done in healthcare today? Is DPC seems like it's normal capitalism, and somebody should need a ruling against it, not that we have to go pass a law to do it. So I just love your remarks on that.
My opinion is, and when I talk to doctors about DPC, is that exactly that, Shahid, that this does not prohibit you from starting, but understand that there is a potential, however slight, that if the department, and it really doesn't impact the physician directly, it would impact, well, yes, it does, but it would impact also the fact if you go, 0 to 60 DPC and all of a sudden they come in and say your model is illegal, and you're kind of out of business, or could be, then you get into court challenges and all that kind of thing. So, but I think to use it as a stopgap in states where there is no legislation, I think that was probably something I would not recommend. Go ahead, get in, and get started. Don't wait for this approval. That's what I'm advising folks in the state of Alabama. There are already a couple of DPC practices in Alabama, one renegade, one from a corporate, one of the corporate companies that are out there doing DPC. But again, I don't think that's a reason to not get going.
Got it.
Outside of the objections that you already mentioned, what do the insurers think about this? If they're going to have a lobby on that legislation, are they for this or are they against this, or indifferent?
My experience has been probably the main obstacle to more widespread DPC adoption is the lack of availability of qualified wraparound healthcare plans to cover for the non-primary primary care type things, the major medical, so to speak, if the patient needs surgery or hospitalized. In most areas of the country, the health plans have yet to really support this with the offering of wraparound policies that fit. Mm-hmm. I think Washington State is an exception, where I know Acute Alliance they actually got written into the ACA support for approved direct primary care practices that have a relationship with a health plan to offer to cover for the non-primary care services. And along with that goes what I ran into with my direct primary care practices. The patients found it really objectionable that they had a high deductible health insurance plan, and the insurance companies disallowed the subscription fees to be applied to their deductible. And so that's an obstacle that if health plans really wanted to get behind the initiative, they would at least allow for the subscriptions to be applied to the patient's deductible. And then there's the whole issue with the high deductible health plans. The IRS has, and I'm going to boil it down to it's very controversial whether or not HSA funds can be used to pay for the subscription fee itself. And there are differences of opinion regarding that, and unless others want to, I won't get into discussion of that, but some say that it does, and most say that it does not. And until the IRS clearly designates that HSA funds can be applied to subscription fees, I think it's the safe path to travel is to assume that it doesn't.
That's pretty fascinating. Dean on the chat basically wrote down that health shares are popping up as a health plan alternative. What do you guys know about these health shares, and could they work well with DPC as he's mentioning?
I don't have a lot of direct experience with them myself in order to comment. So,
okay.
James?
Yeah, so we were also then talking about, so regulatory seems like a real problem and we need to resolve that. How about workforce training? Is the practice, how different is a DPC practice if you decide to go ahead and take the chance to do it, or if it's already legal? What do you have to do to your personnel to get ready for that?
Well, for the health professionals, it's like introducing ducks to water. I mean, you don't have to be clicking off boxes, and you don't have to check how many bullet points you've met and whether or not you you focus on the patient and connecting with the patient. And value-based care is what's the value to the patient, and they typically love that. It can be a real culture shift for the practice starting out, where you're focused on when you have the tyranny of the office visit. If you don't bring the patient in and look them in the eye, then you don't get paid. To where let's do what's in the patient's best interest. That's really huge. Practices. I mean, looking at my own primary care practice, probably 60% of what I saw face to face, at least 60%, I could have done with using a asynchronous media or text or if there were a rash or something like that, getting on and I actually did that. It was a lot of fun using cameras and taking a picture of the rash, and back when I was traveling a lot, I could treat a lot of things by using that type of technology. So when you get off of the tyranny, away from the tyranny of the offices, at which this allows, it really frees you up. But a practice and a culture conditioned to think that the point of care is in the office. No, the point of care is wherever the patient is. That's a culture shift that it takes a little time, but is usually very refreshing.
But Randall, you said that the physicians took duck to water. Is that pretty common, or because when you think about the way that physicians are accessible in their office through regular office hours, is the idea of the subscription and I may be overstating this, but 24/7 availability, is that something that they're taking to because they're accustomed to it, or?
Well, no. Initially, that contributes greatly to their fear factor, because they think they're going to be, they're going to be abused. But if you talk to direct pay physicians, they rarely get called after hours. It's really neat that there's a level of respect that patients they don't want to bother their doctor unless they really need to. There's always that handful, certainly less than 5% of patients that don't understand the concept and tend to abuse it. And so there's a kind and gracious educational process to explain how to use the services properly, and to say, for those, we all have in our practices those patients who have a positive review of systems, and we all fear being on call and covering for those kinds of patients. But what you do is, in a direct pay model, you say, okay, once a month you're going to come in with your list. We're going to address that list, and we're going to exhaustingly, and then it won't be necessary for you to be calling after hours or addressing after hours. So in contrast to what the majority of physicians fear, that this would be a real burden for them, most, if you talk to that are actually doing it and have established direct care practices, they rarely get called.
On the 24/7 stuff, if again, because you're getting away from the compliance and regulatory and the somebody else deciding what is reimbursable, it opens up new tools. And as you said, some of those telemedicine, for example. So it creates the opportunity now where we could take a call center of doctors who could now cover 24/7 for a whole bunch of, say, direct primary care groups. And now it's, as a physician, you're not getting that call overnight per se in every case. And for those, and it's not just a call center staff person taking that call. It's an actual physician, and they can use those tools as you discussed to kind of bridge that gap. So do you see an opportunity out there for that type of I'll say bundling, to steal the term from a couple of weeks ago. Can we bundle that service together and distribute it now out to a bunch of DPC docs, because there's no rules about how you deliver that care?
I'd say absolutely. It's already happening. And I just saw last week where HealthTap, which is one of the many telemedicine platforms, has put I don't know if y'all are familiar with the new, I don't do Facebook Messenger, but they have a program called Facebook Messenger, and they are starting to add chatbots to Facebook Messenger. And there's 900 million users of Facebook Messenger worldwide. They're adding chatbots now, where not only can you order a pizza from within Facebook Messenger, you can get onto HealthTap, and they have 100,000 physicians worldwide enrolled that you can get, quote, if you will, advice, but not a diagnosis over the phone from within Facebook Messenger. And that's pushing it to the extreme. Mm-hmm. But just to say what technology is doing for us, my preference would be, to have that relationship with my primary care doctor first. And if need be, even if they're on vacation, but I'm saying if you can't access in time, then have a telemedicine backup. But I think my preference would be to have that relationship with my DPC doc and being respectful of their time. And one of the reasons we've done that is for over these many years, we have become trained not to, or to at least have some, indecision about bothering the doctor after hours. We know where that goes. Unfortunately, a lot of the times that ends up, instead of bothering the doctor, they go to the ER, which is not necessarily right either.
Right.
I think that's a good point. If you talk to most established DPC doctors I've talked to, their complaint is not that they're getting inappropriate calls after hours. They're saying, it's really the culture shift happens at the patient level too. How can we train our patients that, hey, I'm available, before you go to urgent care or the ER, reach out, call me, connect, I would say the bigger culture shift in education is on the patient side than on the clinical side.
Yeah, that was actually something I wanted to ask your guys' opinion on a little bit more too. Is you said the healthcare professionals take to it like a duck to water, but now there's some new responsibilities and there's some new things that you have to do as a consumer facing business. So when you get into now, you need to market to the patients and you need to get them to buy into it. What are the challenges there? How do we get patients to cut the cord from the what they've had these intermediaries? There was some comments in the tweet chat, and then again on the side here from the tweet chat, they said, I'm a little scared to go out and shop for my own, care in that manner without the protection of the insurers and the government and everything else. And then the comment here with similar lines was having the insurance company involved. Doesn't that enforce a certain level of quality onto the system? So no. How do you guys respond to those fears from the patient side? And then how do we help folks who want to move their practice to a DPC model to understand that exists and then be able to market around that and deal around that so that they can build their business?
That's where professionals need the most help. Is as I said earlier, that whole process of marketing and educating. There are a growing number of entities out there that have been there, done that, and have, through the school of hard knocks, learned what works and what doesn't work. And I would say it's very much a fallacy, depending on a third party to ensure quality. And the best way of ensuring, the guidelines and paths are designed for the general population, but not for any unique specific individual. And every individual has needs and concerns and considerations that render many of these industry-based guidelines as irrelevant. For example, it was very few diabetic patient that I see that doesn't also have hypertension, obesity, have multiple conditions. And all these algorithms designed for single state diseases start falling apart when you're dealing with not only comorbidity but social factors. Just can the patient get a ride, into the facility, and things that I think the evidence is growing that as we depend on these third-party entities to apply population-based algorithms to try to cut down costs, that individuals are going to suffer in the process. In contrast, if you have an advocate, a trained, skilled physician that knows your social state, that knows your preferences, they're going to be far ideally suited to see that you get quality and direct you to the providers in your community that have a track record of being efficient, cost-effective, and high quality. They're going to know better than some third-party entity at a distance working off of algorithms.
I think I'd like to add, too, that I think we all know that the focus of today's EHR, for lack of a better term, and to be pretty blunt, is not the patient. It's not quality for quality's sake. It is quality as it relates to reimbursement. And for that reason, when you approach, and I've approached large health systems about their primary care physicians, particularly those that are, disgruntled, but still have a good patient panel, and are those that may be talking early retirement but really don't want to retire. And the response I get from, and those are typically physicians that are employed by these health systems, the health systems really don't want to hear it because they haven't figured out yet how they get their nickel if the primary care doctor goes to a DPC model. And of course, that's relatively easy to do, but it's that foreign factor, and get out of my sandbox. And I think that's definitely a barrier to getting doctors that would be great at DPC, those that have that mentality and that mindset and that desire to get back to the way they really enjoy practicing medicine. They get blocked, if you will, by their employer. I noticed one of the things that we discussed briefly was about insurance viewpoint. And one of the interesting facts about insurance companies is that I read somewhere that recently that a non-complex clean claim costs the average insurer $1.33 to process. And so if you can imagine the number of primary care claims that get pushed through an insurance company in a year, that would be a significant savings to that insurance company if they would embrace DPC and figure out a way, they've been doing it for years, figure out a way to make it work. It could actually be beneficial to the insurance company instead of taking this combative approach to not having DPC be successul.
So in these cases, then, when you look at DPC, how different do you think it is from accountable care with downside risk models? So in the track 2, we've seen a number of organizations get together and do a very complex environment like ACOs, but aren't willing to do what seems to be a simpler DPC model to get the same kind of shared savings. So why do you guys think it is that a complex group managed ACO model is being experimented with, but DPC seems like a lot more difficult for them to experiment with? Is it because it's not being driven by CMS or some other weird reasons?
NIH syndrome from the insurance companies is a factor too. They didn't invent it. They're not going to support it. They don't understand it. They don't want to take the time to understand it. It's not their forte. Mm-hmm. That's one thing I see.
I mean, it's real simple. It's real simple. I mean, in the ACO model, you look at the physicians that are in there, they are much more focused on clicking off all the boxes and filling out all the reports and getting the data together that's required in order to optimize the business model that is put upon them. In contrast to a DPC practice, the focus is on the patient. What's the patient there for? What do they need? And the documentation and the data collection is secondary to what's in the patient's best interest. As I would say in the ACO, I mean, the patient is a vessel for an allotment of funds that they have to navigate through the system, which is a very different. I mean, at the very fundamental point of care, the incentives are very different.
Yeah, so if you look at the, and this is what a central theme of this particular blab is why things are the way that they are. So if something is better for both patients as well as providers, and we could make it look like it's better even for payers, why wouldn't they pick it up? I mean, I was just at NACOS, which is the National Association of ACOs meeting just 2 or 3 weeks ago here in Baltimore. Packed auditorium of people trying to figure out how to do track 1 and track 2 ACOs. Why aren't these same people also saying, well, why can't I fill a room of 1,500 people thinking about DPC? And that was running through my head is these aren't crazy people. They're fairly well educated. They understand the marketplace. What is it about ACOs? And that's why I think what's going to be interesting is the CPC model. So are you guys familiar with the new CPC? Why don't we talk about that very briefly? It's going to set it up for our meeting next week as well. But maybe now that the not invented here syndrome can be overcome because CMS, quote, invented CPC Plus, it's asking for payers to submit their applications between now and June 1st. And then providers will go from, I think, May or June 1st through August 1st. They're going to start putting their proposals in. So what does this mean to DPC, if anything, meaning from the Comprehensive Primary Care Plus offering that Medicare just announced last week?
Well, first of all, CPC Plus or CPC covers Medicare patients. Typically, DPC, unlike concierge care, doesn't necessarily focus on Medicare patients because Medicare does not allow you to bill for services or double dip in a DPC model. Concierge started really from, I think, what I would call affluent Medicare recipients back in the mid-90s, wanting that time with their doctor, and they were willing to pay outside of Medicare, outside of what they were receiving, an additional fee, typically annually, to enjoy that relationship. And so I look at it this way. I think Andy Slavitt's done a great job in the short time he's been involved at CMS. And I've commended him on a number of occasions, but CPC and CPC Plus still are involving insurance, and you've got all the associated costs with that. Now you're actually complicating it more so because you have traditional Medicare insurance, then you have the 2 tracks that CPC Plus is taking. I guess we'll see. I commend them for taking a stab at it, but in my opinion, truth remains to be seen. And to go back just a second on ACOs, and even before that was the co-ops, all allowed for in the ACA legislation. Co-ops were a miserable failure. The first wave of ACOs financially were a disaster, and now we're looking at phase 2 of these ACOs, and who knows exactly how that's going to work out. But I think going back to the concept of CPC Plus, I commend CMS for at least taking another run at it, taking a different look at it, but it's going to complicate things more, in my opinion. But I'm biased as hell.
Yeah. So Randall, as you think about this, so if a practice is starting to think, if payers are reaching out to practices starting to think about CPC Plus, this might be the most natural time to say, okay, let's evaluate CPC Plus and see if we want to participate with our payers. But at the same time, you guys jump in and provide guidance around, hey, why aren't you looking at DPC, direct primary care, in addition to CPC Plus, because they're both focused on primary care. One thing that I've seen a number of times is physicians start to think like specialists and others wonder if that's going to impact their ability to get referrals and other things from there. So talk, Randall, a little bit about just comments on the CPC Plus, and then how would you evaluate a CPC Plus versus a DPC model? Should you do that at the same time? And what it might mean to referrals downstream to specialists?
Once again, I commend CMS for being creative, but I see the unfortunate challenge with CPC Plus is the same that we saw why, I mean, from all accounts, if you look at the initial CPC initiative, it did not save on costs. And and if you actually calculate in what little bonus there was that was paid, it actually costs more for that population. Not that I think that's the only factor that should be looked at. They did save on hospitalizations, so that's what they tout, and one of the main reasons that they're going forward with the project. I very much support the concept of promoting primary care and first contact. The degree to which any initiative can focus on what's really shown to be of value internationally and in all systems. That's the 4 C's: the access, first contact, being available, having access to it, to provide continuity of care over time, a comprehensive total person approach that helps to avoid a lot of the fragmentation that increases healthcare costs. The problem with CPC Plus, and it's the same thing that's the problem with the ACOs and the original CPC, is the complexity. Mm-hmm. They enforce that once again you have this incredibly complex set of requirements where the focus becomes more on collecting the data and being a data clerk than really being focused on the patient. They need to. I would jump up and down if it were if what they did with CPC is say, okay, we're going to allocate $50 per patient per month to provide all the traditional primary care services, and then get out of your way.
Yeah.
And doing that, I think we could see tremendous success. But what they've done is they've latched on all this faux quality measurement. Annualized performance metrics are not the same thing as quality measures. Yet, we have this pervasive epidemic requirement that all these things be collected, and the evidence is just not there that they actually improve the outcome of patients. And there's a growing body of evidence that they actually lower quality because of the distractions. Patients don't want to go in and look at the back of their doctor's head through an encounter. They want their attention.
But in the spirit, just in the spirit of talking about why things are the way that they are, a lot of what these things are put into place for, whether it's quality metrics or anything else, is to help prevent or maintain the level of fraud that we are at today. So if we said that, okay, here are some techniques whereby we can do the right thing for patients and be sure that no one can do the wrong thing for fraud reasons, I think people would buy the argument. We're all saying that, we're all assuming that all doctors, all health systems, all institutions are in it for the patient, and that's why these will work. And of course, that by and large, that's true. The question is, what about the things that CMS, which is the largest payer in the land of these services, how do they know that they're getting what they think they should get without putting these quality metrics or other metrics? I don't think you're arguing that metrics shouldn't be there. You're saying there should be some other metrics. So what would those look like that would help CMS say, this is realistic. These guys understand that tens of billions, if not more than that, are lost to fraud every year because of insurance. What would we say in those arguments?
Well, I don't think time will allow us to go on a discussion of alternative. But what I'm saying is annualized performance metrics don't equal quality, and they do not give you valid. What they're looking for is something to plug in that would give accountability that there is value being delivered. Mm-hmm. I'm saying that the evidence is overwhelming, and I'll be happy offline to give you a wealth of research nationally, internationally, whether you look at the UK experience with the Quality Outcome Foundation, which was a miserable failure. I mean, the UK is doing, they did, starting in 2004, exactly what U.S. health policy is starting to do now by putting in these annualized performance metrics, and it has been a miserable failure by all accounts in the UK. And our own experience with education reform, with Leave No Child Behind, by using these simplistic measures that that don't really measure the outcome, but measure what can be measured, you actually make things worse. And I'm saying we need to completely revise what we're measuring. We absolutely need accountability, but we're going down the wrong path with performance metrics. We need to look at outcomes. Is the patient staying out of the emergency room? How quickly did they get back to work after their back pain? How many of them are employed after this event? Things that really affect the quality of life of patients, not these other things that can be measured.
Yeah, well, it's a really tricky area, and I just read this morning, it was out of the New York Times. The title of the article was CMS penalizing hospitals for being too careful, and it was all around the fines for the infections. And the position of the hospitals that they were talking to in the article were that we're really careful and we do a lot of extra tests because we want to make sure we catch things, and consequently our death rates are much lower than at other hospitals. But now we're going to pay these fines because we're finding the infections because we're looking for them. And there's some other interesting kind of anecdotes in there about because of the complexity of healthcare, you don't know where that infection came from. So some hospitals, there was evidence of them putting in tests upon entry. They're admitting someone to the hospital and they're running effectively unnecessary tests on them to rule out that they came in with an infection so that they could document that and not have it affect them down the road. So that's the problem with the quality is it's defining what it is, and then two is measuring it. And you put those two things together and it gets out of control really quickly. Something you said earlier was, we were talking about if we took the CPC plus and, looked at it, ironed out some of the complexity of it and just said, we're going to pay you $50 a month per member per month. And, we're going to let you take care of business. That effectively is the DPC model. And, what's Medicare's position on DPC today? Are they talking about it all? Are they largely ignoring it? I know I came across some examples. The one I have here is like Iora Health doing something with Medicare Part D in Phoenix. I don't know the specifics, but how does Medicare feel about this? As we said earlier, the payers are against it. Is Medicare as a payer also against it?
Evidence I have is that they're exploring it. That there are. CMS is an entity with multiple different types of people with different mindsets. But at the highest level, they are at least intrigued. And there was a fly-in last week of several leaders in DPC who met with Conway and Slavitt and some of the big people discussing the model. So I think they're intrigued with it and are exploring it. But I think you have a whole culture that basically distrusts health professionals and is of the mindset that you have to have this high level of accountability that's going to be a difficult obstacle to overcome.
I think one of the most telling graphics I've seen in the last 6 months is the graphic that's been fairly widely circulated comparing the rise of physician supply to the rise of administrative supply. And it's a hugely impactful graphic. I think, along the same line, this project that's trying to get started in Michigan with their Medicaid, they are looking at a pure DPC approach, $70 per member per month on this pilot project. And that's what's going to take care of the primary care needs of that pilot group of 2,400 individuals. Now, they obviously have access to the wraparound piece, if you will, that Medicaid currently provides. And their metrics they're looking at are how the patient does, which is hugely important, outcome, but from a financial standpoint, looking at the rate of admissions, looking at the rate of specialty claims, there are certain pieces that are very definitive in assessing performance, and you don't need the 994 other data points. You need a few data points to show that this is working.
Yeah, and I think that as we think about that, what we need to make sure that we remember is that a lot of the rules that they're putting into place are to prevent fraud. So when we think about these things, let's say, okay, this is why it's going to work for people who will follow the rules, and here's how it will work for those that don't. And the other why, remember, from a why things are the way that they are, AMA, the American Medical Association, has created walls to help, and not in a bad way, but help protect the practice of medicine, to make sure that it is practiced by those that are the most qualified in their professions. And so, as a general professional practice, that's great. But today we know that sensor devices and diagnostic devices can often do a better job than humans could do 20 years ago for certain kinds of diagnostics. Now, because these things are put into place, health coaches and other things which would be nice at pharmacies or the folks that are working in other sectors, they aren't able to do this quote practice of medicine because of the walls that we put up. So we need to make sure that we look at this from a 360-degree angle, not just and say, okay, well, for patients this will be good, and for DPC this will solve these kind of problems. The other kinds of problems, and I think Don, you had asked in your tweet chat earlier, while DPC solves certain problems, it causes new ones. So let's make sure we analyze what those new ones might be, whether it's fraud, whether it's allowing now people who wouldn't necessarily have been able to practice medicine in the past would now be practicing medicine. What would that look like? So I think if we just look at the benefits of DPC and forget that there are going to be significant detriments that are not related to medicine, they're related to the payment of medicine. This is taxpayer dollars, and I'm not at all worried that Medicare doesn't trust physicians in general, because it's taxpayer money. It's my money that goes to pay for these things, and it's okay for us to have a healthy lack of trust, and that's the key: a healthy lack of trust, not an unhealthy lack of trust. And then it should be on the AMA, it should be on the healthcare industry, us as innovators, telling them it's okay. Here's where you can do trust, and where you can't trust, I have systems in place, I have technologies in place, I have capabilities that will find those that are not trustworthy and protect US dollars, taxpayer dollars, from going to criminals and others who would use this capability to make more money when they shouldn't be. So that, I think, is something for us to keep an eye on.
Yep, I agree.
You look at the evidence, the evidence is growing that putting in these into complex systems where outcomes are based on many parameters, social, medical, otherwise. When you take these simplistic accountability measures and then you tie financial incentives or rewards to them, what you end up with is not a more honest or more valid system. What you end up is a higher level of gamemanship, where the focus is on, okay, what data do we need to collect, and what games do we need to play to make the data look good so that we will get the full payment. Meanwhile, the back is turned to the patient, and what's really important to them often gets missed because you've got to focus on, okay, what's the game this month? Have we asked this question? Have we done, I was in a practice last week, a 75-year-old man that is he's doing Ironman competitions. And I had to sit and watch the nurse go through a fall risk assessment for this guy. But that's the game they're having to play. And who can argue that fall risk assessment is a good thing to be doing, but to be applying it across the whole population without exception, because someone is determined that's what's going to improve quality, that's a fallacy that is not improving accountability. It's just creating another level of gamemanship.
Yeah, the back to that New York Times article that I mentioned, that was another point that one of the CMOs made in there was, if we spent as much time on this, pneumonia prevention, in his demographic at least, he felt like that would be a much more effective use of time. It would help more patients that what he's doing, spending time on some of the specific check boxes he was going after in that case. So it's not even just gamesmanship. It's in business, you're going to follow the money, and in many cases, you have to follow the money. It's not like, oh, I'm greedy, so I'm going to follow the money. If I'm going to help anybody, I got to keep the lights on, so I have to follow the money. So I'm going to follow your check boxes, and I'm not going to spend as much time and effort on the things that you're not incenting. And it's just it's a natural course of business.
Exactly. Yeah.
All right, so we are beyond time again as usual. And didn't even get to question 3 because I believe question 3 was about is the technology there and ready to go for this. Am I right?
Yes.
Yeah. So maybe we got to do a little bit of follow on. We could probably blend some of that with the CPC plus conversation next week, I'm sure. So it's at this point, I'd say we wrap things up. You guys got any last words you want to throw out there?
Just thanks very much to everybody. It's been fascinating. Great opportunity to discuss things that are very important, certainly to all of us, in different ways, perhaps. But again, I think the opportunity to get thought leaders together and really hash these things out is so terribly important, and I appreciate the opportunity.
Yeah, I appreciate you showing up every week. I think you've been with us since the first one. I don't think you've missed any. I appreciate that.
Either I don't have enough to do, or I really like what we're doing.
And Dr. Oates.
I hope it's the latter.
Yeah, right.
It is the latter.
Appreciate the invite to participate, and I look forward to more in the future.
Yeah, awesome. It's good to see new faces on here, and I hope to keep that up. So thanks again, Shahid, and I'll touch base with you on some of the CPC stuff, and we'll put on another good show next week.
Thank you, Don.
That's great. Everybody should sing the siren song of HCBiz, which is disintermediate, disintermediate, disintermediate.
There you go.
Do that,
Love it.
Way of succeeding.
There you go. All right. Awesome, guys. Thank you so much. Have a great day.
See ya.